Um, Today we're going to talk about a few things about when should your patient wear spectacles. Actually, I'm not going to give a comprehensive account on spectacles here because it's a 4-year duration degree course actually. So I can't make it a very summarized to a 1-hour lecture here. We'll try to do as much as possible that we can do here. Spectacles are used for getting a clearer vision, to alleviate some of the symptoms, which I will tell in this in few slides, to get rid of squints, and then for cosmetic reasons, and also for some other reasons. If you take this first three, it looks like therapeutic, and the last one cosmetic. So basically, for therapeutic and cosmetic reasons. Even the third one, getting rid of squints, also we can take it as cosmetic sometimes. I think you can remember your eye, the anatomy, which consists of cornea in the front of your eye, consisting of 2/3 of the refractive power of whole eye. And behind that, a lens made of crystalline proteins, we say it's a crystalline lens, and contributes to 1/3 of the refractive power of the whole eye. Together, that two focus the image on the retina, that is converted to impulses along the optic nerve, and they go to your occipital cortex, and then we see out of our eye, provided that the media is very clear. Media mean the whatever in between this here the vitreous, or in here the anterior segment, or here the cornea. This we all know, electromagnetic spectrum with various wavelengths that we know. With higher wavelengths, we do X-rays, and with lower wavelengths, we use it for our microwaves, TV and radio, telecast and broadcast. In between that too, there's a very small spectrum that our retina are sensitive to. In that spectrum, we get blue color towards the higher frequency, and the red color, warmer colors, red color towards lower frequency. And some retinas are more sometimes sensitive to frequencies beyond this red, so the infrared. So that's why some, not people, some animals see in night as well. Visual acuity is usually measured with Snellen's chart, even though we have some other methods. That's the commonest method we use. And it consists of measurable vision of 6 out of 3 to 160. 3 to 160. But these letters might not be familiar to us. But you know what is 6/6 is? 6/6 is, actually, it's not the normal vision. It is the lower limit normal of the vision that a human should have. And we use this Snellen's chart to your right-hand side. The one with the letters or the numbers we can use in day-to-day life to check the vision. The top letter, which is E, has a angle indentation in our retina of 5-minute arcs. So we are talking in minute arcs as far as it's the indentation of the objects in the retinal images are concerned. In this E, you can see 5 bars. There are 3 black bars which goes in one direction, and in between that 3, there are 2 white bars, isn't it? So all together makes 5. So when this Snellen chart is situated 60 meters away, a normal person can see the top letter. So that's why it is 60. The number is given is 60 meters. The same way, the one just above this red line is the 6/6 line. It means this Snellen's chart, if it is situated 6 meters away, a normal person can see that letter with one eye. Then we say monocular vision. If you can see with both eyes open, then we say binocular vision. Especially in driving, we check binocular vision. That letter is around 9 millimeters in height in the exact Snellen's chart. To your left-hand side are the illiterate Snellen's chart, where people don't understand much, can say where the bars of the E are directing to, or the defect of that C is where that direction is. There are various ways that we interpret the vision. The second column is what I was talking now. The metric method, 660, 266, and 63. Actually, humans, especially kids, are having a vision more than 6.6. But we take it as 6.6 for our convenience to be the least amount of vision we should have, either with or without correction. The United States use this feet method. Then the 6.6 comes 20/20. Okay, vision is not merely the visual acuity. It has three other components: contrast sensitivity, color vision, and visual fields. If somebody says, I can't see, and if they have 6.6 vision, he's not always psychiatric. They may have some other problems. But in spectacle using, we are going to use most of the time this visual acuity managed. We can check color vision also with Ishihara chart, which consists sometimes of 38 plates or 17 plates, which has a lot of colorful circles and numbers in it. Spectacles, coming to the square one today, used for getting a clearer vision. That's the first reason I figured out earlier. In ametropics, what is this ametropics? If we put letter E, except this A there, it becomes emmetropics. Emmetropics means normal people. If it is not normal, this is ametropics. Okay, we'll see what are these ametropia things are. The first one, the top one here, the cursor, can you see the cursor? Anyway, the top one is the normal, we consider as a normal one. The second one, the middle one, is hypertrophic. If you carefully see, that second eye is little shorter than the first eye. For that reason, this image is focused back of the retina, behind the retina. So what we need to do? We need to get the image forward. How we can do it? With another convex lens in front. Very easy. If you go to the last one, you can see the eye is long. When I say long, it's not in meters, it's not in centimeters. It's just like a normal eye is like 22 millimeters. And when it is big, then it's 23 millimeters or 22.5. Actually, this 1 millimeter makes the difference of 3 diopters. In a normal person, it is the near vision to the infinity, 3 diopters. And in this myopic eye or the long eye or the nearsighted eye, we can get this image back to the retina a little backwards by using a concave minus lens in front. Very easy, isn't it? Okay, there is another type of ametropia which I will tell in a minute. About presbyopia also, the mechanism is different. How presbyopia happens, it is due to the less flexibility of this crystalline lens. When you have, when we grow older, beyond 35 years of age, even though our ciliary muscle contracts, even though our sonules get relaxed, our crystalline lens might not come to a convex shape. Then the power is lost. So this lost power, we can add from the in front of the eye. So when you put a plus lens in front, then we can correct this presbyopia as we do it here. I'm sorry, if you can see, there's a light color lenses. Lenses are always light color, isn't it? So it's here. And astigmatism, the other type of ametropia, it's a bit difficult to explain. It has not a football-shaped cornea, it has a rubber ball-shaped cornea. So in certain meridians, the curvature is more or less. So we're going to correct it separately in various directions. When you have astigmatism, you can see along the meridian that you have gone wrong, these halos of straight lights. If you see this, yes, you can go and ask your ophthalmologist whether you have astigmatism. If they say no, then it is no. You don't want to go for a second one, because sometimes it might be something to do with your windscreen, or maybe it's normal to everybody that you think it's not normally new. Ametropia, again, coming to a summary, myopia corrected with minus lenses, and it's very commonest out of all the ametropic errors, and might be progressive a little, unfortunately may go even more higher, pathologically progressing up to minus 15, 20, 25, even 30 I have seen. And the lenses become very big, the eye globe become very big. Sometimes it's visualized as a proptosis in very high myopic patients. But if you take the normal population, 60% of us has refractive errors. But if you count who are less than 40 years, it's only 5 to 10% we are wearing glasses. How it is happening? Because we can make up or we can control ourselves up to 75, 0.75. So it's called 75 vision. Beyond that, we can't, so we need some glasses. Sometimes even minus 1.5 is also I have seen, they are managing very well. I'll come to that. Now, when a student will go, what are the lenses that we're going to give for the clinical scenario? If we have a kid with not 6.6 vision, it's 6.9 or 6.12, and with correction, they get 6.6 vision. Let's say now the kid has come for some other reason to your ophthalmologist, and we detect refractive error now. And when we ask, Puta, can you see everything? Yes, I can see. Do you want glasses? No, I don't want. Then we don't want to forcefully put glasses because he has a correction of 6.6 vision. Then we need to be very careful, follow up them very closely to see whether they maintain this 6.6 vision. But if they say, okay, I would like to wear, and if they see that, okay, the world is more beautiful than otherwise, then they will continue with no harm. But if they have a lesser vision than 6.6, it means 6.9 or 6.6 minus or 6.9 minus, then we can't afford to do nothing. We need to give the glasses to maintain, actually to stimulate the cerebral cortex, which has not already been stimulated. That is called patient is amblyop due to a refractory error. With the glasses, we can stimulate their eyes, the brain through the eyes to see more, because finally they need to have 6.6 vision, especially when they are going, when they have some other aspects like being a pilot or driving without any problem in future, right? Or in some certain, what do you call it, occupational things. When we correct myopia, actually studies has found this correction itself aggravates this problem. But can we not wear it? No, we should wear it. And also near work, not the screens, only the screens, but also any kind of a near work, book work, screen work, or whatever aggravates myopia. I'm not talking it's going to minus 10, 20. It might go from minus 1.25 to minus 1.5, right? And also it's better, some studies have found that the kids in between minus 2 and minus 4 are more intelligent than the age counterparts. I don't know how it happens. If you have children without minus, don't worry, but they might be very intelligent. I'm also minus 1, not in that category. But it aggravates, but we should live with it. We need to give the glasses. Okay, in COVID season, especially in the Eastern world where the myopia is commoner, they found this myopia progression is very high. Then everybody thought, oh, this is the screens. Australians did a nice study. They got one set of students to use near work, screens or books or whatever in indoor stadiums and homes. And they make the other students to read outside the home, in sunlight, in garden. Then they saw, when they use the same time of screen work or near work, these garden students are less progressing than the indoor students. Then they finally found, oh, this is the sunlight causing this problem. Actually, not having sunlight is the one which is causing this problem. So there is something in the sunlight which prevent progression to myopia. Okay. Presbyopia is welcoming. If we have myopia, then even after 40 years of age, we can focus the near images on the retina. If you could see now, I'm myopic. Actually, I can't see this properly. So when I take this out, I can see very well. Okay, even at my age, you know my age now. Hyperopia, we discuss corrected with plus lenses, astigmatism, which is corrected in two directions separately, is called toric lenses. Spectacles are also used for, what is it here? Okay, if a kid comes with certain symptoms of refractive errors like eye pain or headache, still they have 6/6 vision, then we need to be very careful to go and see how they are checking their eyes. Because when they have a small error, by doing like this, they can get 6/6 vision. It means they are ametropics. So we do a nice thing called wet refraction. We paralyze their superior body with drops, and then we can check what the exact power of the eye is. Then we can couple it with a dry refraction or without drops and see what are the real glasses they want. Amblyopes are the individuals who has a lazy eye, I mean they are not seen properly despite having a normal anatomy everywhere. What has happened? The retina has not become successful to stimulate their cortex as it should do. It happens when there is a correction. It means refractive error is there. Then we can stimulate, as I just told a minute ago. And also, most of them are having straight eyes. They don't have squints. But in squints also, in squinted eyes also, in strabismus, these kids may have some corrective errors to be corrected, refractive errors to be corrected. Then we need to correct it prior to the surgery. We don't want to see the stereopsis or the muscle working, muscles, neuro studies or anything. We need to correct the vision because after correction of the squint, they can go back to their squinted eye because they don't have a proper fusion. In light scattered environment, now if you go out, the light is, if it is sunny, the light is scattered, isn't it? So we can use spectacles to reduce this scattered light environment for us to see better. I will say it in next few slides. Okay, we may go kids with poor vision unnoticed, something we can't afford to happen. Okay, in Sri Lanka, MOHs are advised to check vision of school kids at grade 1, 4, 7, and 10. If the student counts is less than, so more than 200, but if it is less than 200, they have advised to do everything in one go. Some parts of the country, especially when I was working in eastern part of the past of Sri Lanka, it was nicely happening. But in some other areas where there are the lot of municipality works is more, they are not much working properly. But it's our parental responsibility to check whether the kid can see very well, even at these ages. Why these 4 ages? Because I told them my opinion is progressive. In each age, they can get progress. So somebody who's having nothing at 1 may have something at 4, right? Obvious signs. Your kid is going very near to the television. Yeah, it's an obvious sign. They say, I can't see properly in the book. Yeah, it's an obvious sign. So they, in dim lights, this subclinical thing can come out and they can go and collide with walls, tables, or this thing. I'm not talking about diplopia, the night blindness. These refractive errors also come up in dim environment. So it's an obvious sign. And they might prefer the front line of this classroom. They can't go back. So it's an obvious sign. So then here we go to an ophthalmologist or the optometrist to get it corrected. Oh, okay, one other thing. If you take, this is a common thing that we do is called photo screening. Then when you take a photo, we can ask the students, oh, come here, say chi to my camera, and red reflex reduction is off, right? Be careful. And you take a photo, all the red reflexes you can nicely see in the photo when you get the printout. And if you detect some student, a kid, who's not having a similar reflex coming from both eyes, then it's the occasion that you need to go to an ophthalmologist. Visual problems will not cause learning difficulties. Once you get rid of this visual problem, the learning ability is the same. They may have some difficulty in learning when they have poor vision. I mean, learning difficulties and difficulty in learning, so I think the pediatricians are psychiatrists, some of who conversant with these words. But visual problems, once the vision is corrected, they can end up in any amount of hires in society. There are subtle signs, 4 subtle signs basically, the American Academy of Ophthalmology says. First thing is having a short attention span. Now, the today topic is when should your patient wear spectacles, right? Okay. Having a short attention span, if the kids are not, they may have ADHD or some other spectrum, but usually if they have nothing but they are not much interested, keep on carrying some work, it might be some kind of a vision problem. Second one, losing their, when they read loud, they can't find the other line, then we should be careful. Avoiding, not only interested, they avoid any close work, then they might not see properly. They don't know how to tell it, isn't it? If they do ophthalmology, they will tell it, but they don't know it. They just see something odd. We are the people who should be careful about that. Turning their head to a side. By doing this, certain errors can be partially rectified. So if they do this, we need to check the eyes and also the ears, because it might be this ear hearing, but not the other ear. Presbyopia, back to presbyopia again. Okay. When we are very small, humans are very small, they have an amplitude accommodation of 15, remarkable. But when you grow older, 40, then it comes down to 4, and even more older, 2.5, 1.5, something like that. So we need something extra, additional to see near. Near point of vision mean, what is the nearest point that we can see without blurring? It goes away from us when we go older. At the age of 40, it's like 25. That's why we are keeping it at 25. And even at 50, it's 40. So we need to give. As far as our arm length is wishing us or blessing us, we can manage it. After that, we need glasses to get the vision. And also, this correction need not to be full. For an instance, if you give a full correction to a 35-year-old individual, then you are giving the accommodation from outside. Then he's not anymore interested in any accommodation. Then he can't do any near work. If his glasses are lost, then he's lost. So we should correct only to the extent that we should that individual is satisfactory with. For an instance, recently, very senior consultant in our hospital came. So senior means almost near to 60. Her correction was plus 2.5. Is it correct? Yeah. Yeah, something like plus 2.5. I think after this, yeah, 2.5. I will tell it in another slide. But I gave only +1 because she's very happy with +1. She's blessed actually, right? So this Royal Air Force ruler, we can check the near vision of individuals and see whether we are how our accommodation is. As a rule of thumb, this is what I was telling a minute ago. Additional power can be given by the age. By 40, we can give 0.5, 45, 1, 50, 1.5, something like that. But you don't need to give exactly that one. You can give a lesser value if the patient, if they are comfortable with, because otherwise we are abolishing, especially before 50, we have some accommodation, we can abolish that as well. So I have seen individuals coming at age of 40, so it's here 0.5, they need 1.5. Why? Somebody had been very enthusiastic and they have given +1 at the age of 35. Okay, but at the age of 35 also, unfortunately, if they are not comfortable with near vision, if they have a headache or eye strain, okay, then we don't want to wait. We don't want to ask them to do a lot of eye exercises or eat a lot of flesh or eggs or anything. We can give glasses. Percentage of accommodation here, this is here, I can't see. When you say 50 years, if you take this 50 here, can you see the cursor? 50 years, I think it's 50. It's 50 here. And with full accommodation, he can see 40. With partial accommodation, he can see 60. So if we give a full correction, this whole accommodation is gone, right? Okay. When do you say is your vision is satisfactory? It's very simple, the answer. If you are comfortable in all your day-to-day work, then your vision is okay, right? So if you have a glasses taken 5 years back, When you go to an optometrist, he say your power is changed. But if you are still happy with your existing glasses, that's it. You don't have to change it. But if you are not happy, then here you go. You need to change it, right? Then if a presbyopic, let's say 50-year-old male at home, find it difficult to see, then he wears his wife's spectacles. He's happy. Yes, okay, then no problem. But if wife's addition is more than what he needs, his accommodation can be abolished. That should be kept in mind, right? But this is not the same thing in kids. If they have amblyopia and a refractive error, we should give the proper lens to them. They can't wear somebody else's lenses and see nice. I mean, even they are happy, they can't use that because near corrections might behave the same, but it's different. Okay, now I was talking, are you satisfactory? Now this one is standards. Even you are satisfactory with your vision, if you don't have a proper vision, we can't allow for you to drive. It's something to do with other one's slides. So in Sri Lanka, you can see here, this for all these what do you call it, vehicles, we need to have 6:9 or 6:12 vision in both eyes, vice versa. If you don't have that, even you can see everything, you cannot be drive. I mean, you need to wear spectacles or correction or whatever. Spectacle and corrections are two different things, I'll tell you in a minute. And also for occupational recruitments, if you can remember, I told. We'll see what are these glasses, type of glasses actually we have to wear. Ultra thin multi-coated glasses has so many layers on top of glasses to have anti-reflective. Then whatever been put on our glasses is not reflected back. So outsiders can see our eyes very well. At the same way, some of the waves which are, what do you call it, light waves, which comes to our eye is reflected back, isn't it? Because we have a mirror finish in our cornea. Then this light can reflect it back from our glasses. When it happens, then it makes a very noise. So we say it's a very glare. If we put this coating, then there is something called destructive interference or something. I have a slide about it. And then it is negated and you can see very well. Hydrophobic layers, anti-scratch or scratch resistant layers. Then it becomes UTMC. Okay, destructive interference, I'm correct. So it causes this destructive interference and make it glare very less. Glare is something like this. Into your left-hand side, it's a glary. The other side is not so when you wear UTMC glasses. And also, that's what I say, that we can see that eyes of the individual very well when they wear UTMC glasses. Okay, blue cut. This is very interesting topic in the world of spectacles now. Actually, this is a trading something. There are no studies being found to tell that blue light is damaging your eye. There are no proper studies done. But the next frequency, ultraviolet, is that ultraviolet? Yes, ultraviolet A, B, C. Usually we have ultraviolet A and B in sunlight, isn't it? They can make problems in our eyes, especially macular degeneration can happen, cataracts can happen, but not the blue light. Actually, blue lights keep not producing melatonin in our body. So we are kept awake. That's why this, if you have gone to seasonal countries in summer, where there is sunlight till around 10 o'clock, people can't sleep because melatonin is not produced. To produce melatonin, we need warm colors. That's why some red color lights are in sleeping rooms, isn't it? The red color, they can produce more melatonin and we fall asleep quickly. And in this technology, if you put a filter, these blue lights are taken away. I'm telling that because it is there in the market. Then blue light is not coming to your eyes. Actually, blue light sometimes causes some strains. I agree that. And also, if you were in our country where sunset is at 6 o'clock, if you use computers and phones till around 10 o'clock, our sleep rhythm or the circadian rhythm is get disturbed because of the blue light. Oh, what you can simply do, all our these technologies are having a blue filter or the night mode, isn't it? Where the blue lights are not coming. So it's same as we putting a blue light, blue cut glasses. If we put blue cut glasses, then we need to use that and daytime also. We don't know still what is the damage is going to happen without blue light in our eye. I just told that myopia sometimes progress. So especially in myopias, we should not do blue cut because there may be something to do with glasses. Sorry, sunlight. Okay, this reflected blue light we can see from outside. We can see a nice bluish kind of thing if they are wearing a blue cut glasses. Polarized, very simple mechanism. For us to see something, light should be reflected from. When the light waves are coming in one meridian, we can see it nice. But when it is coming from other sources also scattered in other meridians, then there's a big noise. We can't see it properly. That's why in light scattered environment, if we use polarized sunglasses, polarized or I would say polarized glasses, even with tinted or without tinted, we can see very well. You can have this correction I told earlier with the polarized glasses, but the disbenefit is it's costly. Okay, in the picture top, you can't see properly, but the family crossing the road can be easily seen with the polarized glasses. Actually, I saw in a Russian driving lesson, in night, when you have a pouring rain, in night, we can't see properly, isn't it? But you can nicely see if you wear sunglasses. That is because of this polarization, right? Bifocal versus progressive. So far we discussed this myopic, convex, concave, toric lenses. They all are monofocals. And when we come to our presbyopic age, we need to use bifocals to distance vision and near vision. Like this, you can see that bottom part. You can see the addition here. Some individuals don't like it, so they can use a progressive one, which is here. So in progressive one, another advantage is this distance part and the near part is seen at the same time. The intermediate part also seen nicely. But whereas in here, the intermediate part is lost. But the disadvantage of this is, till you get used to it, the peripheral images can be distorted. So the day you wear the progressive lenses, you should not drive. You need to look at certain familiar things first. And here, the advantage is you don't have the distortion and you have a big chunk to see, the near and far. But here, you have all the grades for you to see from far to here. With the progressive lenses, it is done, the job is done, which it could be done with several glasses. And these bifocals are coming with this executive bifocal way. So this is for the near vision, this is for the distance vision. This is called Benjamin Franklin, if you can remember, the person who invented USA. And also Steve Jobs, he was wearing this. Flat top and this ribbon. And I don't know actually what is the ribbon is for, but it's stylish one, I think. The round one. This all how we should give the particular thing to a particular individual is the way they are, like the jumping of the image from here to here, because they do have different optical centers. So when we see from here to here, there's a jump of the visualization, then we don't like it. If you're myopic, you can't use this. If you're hyperopic, you can say likewise. So if when you're above 40 years, you can discuss with your optometrist and ophthalmologist what type of a glass you need. Trifocal is also, it's not much available, but this trifocal, which has various levels of seeing, became progressive later. This distortion also I just told is sometimes now taken out with higher technology and with a higher cost now in progressive lenses. Executive bifocals, the Benjamin Franklin thing is like this. Okay, transition glasses. This happens when you go out to the sun because of ultraviolet light, not by the blue light, ultraviolet light. Graded exposure, graded coloring, more exposure, more coloring. It happens because of this silver, chlorine, something, a chemical reaction happens, they dissociate and then silver and chlorine separated and they become black. And in cold weather, it becomes like this. And in colder weather, this reaction is very slow. So when you go to a colder country, in winter, when you come into the room, you can't clearly see properly for about 10-15 minutes. And this we can use in indoors, it's like this, and outdoors, it was like this. Okay. We wear glasses to alleviate some of the symptoms. Photophobia, I'm not talking about meningitis. This is photophobia. Some of us actually, we don't like very high sunlight, isn't it? Very intensive sunlight. So we can use this transition or the photochromies, which I just shows in the previous slide, and tinted glasses. But sunglasses also a type of tinted glasses, right? And polarized glasses to get rid of this photophobia. Headaches. If there is a refractive error, people get headache. Sometimes unusual headache, they can't find. And finally, the neurologist send the patients to us. Everything done, nothing happens. Then they have a small refractive. Actually, very small refractive errors can cause headaches. That can be diagnosed when that, especially kids, are going in sunlight. They are very okay with sunlight, but when they come home, they have a headache. When they don't go out, they don't have the headache. Very simple. And if they have a poor accommodation, the muscles are not properly working, we can give some subjective myopic classes for them to have more accommodation. I told you the myopia is progressing because they are focusing a lot. So that can be done as a therapy for a poor accommodation here with subjective myopic classes. Digital eye strain, another very interesting topic. This line is another lecture actually. It's called CVS, Computer Vision Syndrome. It's a separate subject. Studies has found digital eye strain is not by the blue light, it's by less blinking and refractive errors. Every 4th minute, we blink. Okay? But here in this audience, we are not blinking that much because you are looking at this screen. So you blink every 15th second. Then our eye, the tear film is evaporated, especially in this air-conditioned weather. Then we get this eye strain. So it's very simple. If you revert it back with the I told that it's a separate lecture out of this scope. But one of the good way is to use UTMC glasses and some lubricants. Other therapies to get rid of squints. Yes. Squint is actually another big science. There are various types of squints. If you have accommodative esotropia, it's a type of squints, actually don't want to think about it. Then if you give glasses of +3, they can, this squint is gone, right? If you take the glass back, then the squint is coming back, right? We can do surgery also, but it's not advocated at this age, but we can do later when it is decompensating. Other therapies, yes, to treat ptosis. Treatment option for a ptosis, we can give crutch glasses, something like this. The crutch is here, and this ptosis is taken out. So the cosmetically it's good. And also patients, if the pupil axis is covered by the elevator here, we can elevate it and the patient can see. For cosmetic reasons, we can use plain spectacles. Oh, I mean, some people, they want to wear specs, isn't it? They feel like it's very nice. Yes, sometimes it's very nice. So they can use, it's another reason. Tinted spectacles, whatever this sunglasses or tinted glasses. Okay, here, sunglasses. Here, it's tinted glasses. We like his voice. See how beautiful the glasses are. And here, the Simon again. These are the tinted glasses, right? Okay, for protection of, actually, this is not a glass, this is a goggle, but we can use glasses also. Can you wear goggles to cook? No, you can't, but you can wear a glass, isn't it? So this oil flashing and things are not happening, right? So we can use glasses for protection as well. Well, I'm at the end. Other options than the glasses. We can use contact lenses. Then we don't want glasses. In certain, most of the refractive errors can be tackled with contact lenses. The contact lens is another science actually. And laser treatment to cornea, we can say LASIK with their various types of corneal surgeries, laser surgeries. Then you can, to do that, your eye should be stable. If a individual of 20 years of age go and do this, if when their eyes are not stable, I mean, if the myopia is progressing, yeah, he might see very well the next day, but by another year, he needs glasses again. You can't keep on doing LASIK on that time. Clear lens exchange to multifocal IOS, actually, for my surprise, I got to know very recently in India, this is happening very much, very frequently. So when they come to age of 40, they don't want glasses. So they get the clear lens out, crystalline lens with the help of ophthalmologist, and they put a multifocal IOL, not a monofocal. We usually in Sri Lanka, 99% of the 99.9% of the time we put monofocals, where they can either see far or less, sorry, near. To see the other thing, we need glasses. But by putting multifocal IOLs, there's a big discussion whether the contrast sensitivity come down. Some people say yes, it is so, but some people say it is not so. But it's another option than your glasses. Oh, I'm done. Yeah, is it too early? Okay, right, good. Now am I going to show these MCQs? Okay. So what is next? Okay, so shall I finish it? Okay. Do you need answers? No. Okay. So these are some of the funny MCQs I made. Thank you. Do you have any questions, please? Yes.
Technical treatment for screen.
Yeah.
Is there a age limit where you could try to start using spectacles?
Yeah. Now, let's say two individuals having correction, no screens, having a squint, no correction, having a squint with correction. There are three individuals. The first one, actually, if we detect that the kid can't see at the age of 2 or 3, we can try using glasses, but it's not practical. What we say to mothers, okay, try using, if the kid threw it away, doesn't matter, because we have up to 12 studies has done up to 21 age to tackle amblyopia. If you have amblyopia in one eye, you can close the good eye with the glasses and stimulate your retina to see the image at least 2 to 4 hours a day. It's a remedy. So by three months, they have much improvement. And with time, sometimes, well, I don't know whether sometimes or most of the time, it comes to 6/6. Contrary, sometimes when 3-year-old kids are given glasses, we can't take it off. They are not allowing. Parents should take it off when they are sleeping. And once they get up, they cry for the glasses because they can see the world very nice with the glasses. Both ways it can happen. There are no age limit. But for the contact lenses, they say after 8 years. It doesn't mean that 8 years you should wear contact lenses. If the kid is not compatible with that, you can wait till they are compatible or they are comprehensive for that. But by the age of 8, we can use contact lenses. For glasses, no age. For squints, again, no age. Actually, if they have a squint and a corrective error, which we detect from the wet refraction, we need to put the glasses even they are months old, because we need the correction to good vision for the squint surgery not to be in vain. I mean, wasted. You know what I mean? Yeah, please, any more questions? Say it again. Yeah. So you're asking whether there are absolute indications or contraindications?
Indications for contact.
Oh, absolute indications for contact lenses. Well, contact lens is also another big topic. If we take therapeutic contact lenses, I can think one thing. Now, if a kid, let's say a 12-year-old kid comes, well, 14-year-old kid comes, and his vision is corrected with glasses from 636 to 69. Okay. And when I ask them to do a contact lens trial, they have 6 vision. Then it's an indication, because we can't afford to that kid to have 6/9 at the age of 30. So if with contact lenses, if that the kid rebel not to wear it, it's a different story. But if they are okay, it's a kind of a absolute contraindication for, sorry, indication for them to get the 6/6 vision. And if you take other, not the refractive contact lenses, there are so many indications for contact lenses therapeutically. I think the answer is correct, because this is something to do with vision and spectacles. But if you have so many things, if epithelial defects and your sutures are not properly working, then you need to wear contact lenses. Yeah. Dr. Krishna, any question?